So, good afternoon, everybody. Thank you, AIOS, for giving me an opportunity in this academic feast. And there is no financial interest in this presentation. In our day-to-day clinical practice, we encounter the patients of uveitis, and as Dr. Deepankar mentioned, that majority of these patients are of anterior uveitis. Sometimes it's really a cakewalk, but sometimes the situation is a little tricky. So now, coming back to the business, that's how I will manage, or we will manage, the patients of anterior uveitis. So this was a 12-year-old boy who presented in the OPD with the history of both eye blurring of vision and redness from last 10 days, and the history of similar episodes were there from 2015, and the last episode was 4 months back. He was treated elsewhere with the antibiotic and steroid combination previously, and there was history of joint pain and lower backache from the last 8 years. So a slit lamp evaluation was done. In the right eye, the KPs were there over the endothelium along with the flare 1 plus and cells 2 plus. And in the left eye, it was KPs along with fibrin, flare 4 plus, cells 4 plus, and a streak hypopion was there. On systemic evaluation, the small joint deformities both in the hand and feet were noted along with the knee joint swelling. So a systemic evaluation was made, and what we found that there was this boy was ANA positive, HLA-B27 positive, RA factor was negative, so it was a case of juvenile idiopathic anterior uveitis. So we started the patient on topical steroids and cycloplasics. Right eye responded very nicely, but in the left eye, the hypopion was still there. So the plan was changed because I haven't reached the complete remission. So the patient was put on oral steroids, 1 milligram per kilogram body weight per day, along with the proton pump inhibitors and calcium. It responded, but within a month, the patient came back. And since we cannot continue patient on oral steroids because he's a kid, so in association with the pediatric rheumatologist and pediatrician, we switched over this boy to oral methotrexate 0.45 milligram per kg per week. And this kid was monitored, and from last a year, this kid is really doing very well. So the crux of this entire discussion is that anyhow we will have to achieve the complete remission. A patient of anterior uveitis, particularly a kid, and a patient who is having juvenile idiopathic arthritis or HLA-B27 associated anterior uveitis, anyhow you will have to achieve the complete remission, because all these kids or these patients, they have some amount of inflammation always persisting in their eye, leading to the various complications. So really we are going to treat all these patients by the means of topical steroids or oral steroids? I was on leave, and this 60-year-old lady came to the OPD. One of my residents examined this patient. She was having the complaint of blurring of the vision in the right eye. The best corrected visual acuity was 6/18 and 12. The intraocular pressure was raised. Reaction was flare 2 plus, cells 2 plus. Fundus was pretty normal. And my resident started this patient on topical steroids and cycloplasics. After a week, patient turned up, and the patient hasn't responded to the treatment. My resident thought that is there anything missed? So this patient was brought to me. We revisited the case. There was the history of fever few days before. There was an important finding that intraocular pressure was raised, and there was sectoral iris atrophy. So these 3 points were missed. The patient was investigated, and we ordered ACTAP for PCR. And what we found? That aqueous was positive for varicella zoster virus. So we put the patient on antivirals along with topical steroids and cycloplasics along with the anti-glaucoma medication, and the patient resolved. But really, every situation is like that. There is a saying from Shakespeare that all that glitters is not gold. So any cell in the anterior chamber is not always that aqua cell. This is a case by my mentor, Dr. Jyotirmay Viswas sir, while I was doing my fellowship under him. This 8-year-old girl presented in the OPD with unilateral hypopyon uveitis. I did a battery of investigations, everything comes negative. The patient was not responding to the topical steroids and oral steroids. Then I went to JB sir and asked what to do. He asked me to go for the AC tap and send that sample to the histopathology. And what we found, that it was a basophilic cohesive tumor cells which were suggestive of retinoblastoma. So beware of masquerades while managing a case of anterior uveitis. So the take-home message is that meticulous history and detailed clinical evaluation that is really going to help you in diagnosing what is the etiology behind this inflammation, and accordingly you will have to tailor your lab investigations, and then the ultimate aim in the management of anterior uveitis, particularly if it is a non-infectious one or an infectious one, you will have to achieve the complete remission. I am grateful to Dr. JB who has taught me the nitty-gritty of this subject, Dr. Hitesh who has given me some clinical inputs regarding this presentation, and my resident Dr. Shivangi and my optometrist Saurabh Sumangalam who has provided me some beautiful pictures of my patients. Thank you so much.
Thank you very much, sir. That was an excellent presentation, all the three